and also the children. We've brought in the children here in Australia. That's the move. At the moment, we are fairly rapidly trying to get the children vaccinated. So we're going to hear about that. And very importantly, we'll have in our discussion this important aspect of mandating. Many of the countries have mandated vaccines for nurses, for healthcare staff, and for teachers and so forth. And of course, that's an issue that we're going to discuss. So as we normally do, I'm going to now ask Professor Mary Matthew, the co-chair, to welcome and to say her words before we go on. Over to you, Mary.
Thank you, Dr. Russell, and good day to everyone. It's lovely to see all of you back again after 2 weeks. We are continuing our series on COVID webinars, and which we started a year ago, and we have reached our 49th webinar. And today's webinar is even more relevant and important because we're going to continue our talk on vaccines and the burning issue of whether children need to be vaccinated because schools have remained closed and there's hardly any education that is offline. And with us, we have very eminent speakers, and it's always lovely to see all of them back again. And we also do have Professor Marco, who's a new entry to our webinars, and we'd like to welcome him. And as usual, as always, please feel free to put your questions in the chat box. We are live streaming this. Dr. Derek will give you the house rules. And let's enjoy this webinar. So thank you very much. And over to Dr. Derek.
Okay, Dr. Derek will give you
thank
house
you,
rules.
Dr. Russell and Dr. Mary, and welcome everyone. Always good to be back here. The live stream link on YouTube is pasted in the chat box, so you can copy it from there and share it with anyone else that would like to see this live, or maybe later. It will also be available as a recording at the same link. As Professor Mary has told you, you can put in your questions or comments into the chat box, and we will address them to our speakers and our panelists given the time. If not, I encourage all our speakers, panelists, and even the other experts that we have attending, in case you would like to respond to anything that is there in the chat box, please feel free to do so. Again, you may also share any links or any other information that you have with you as a document, because we have a large number of students who are participating and who also view the recording later as well. So you can share the documents, you can share the links, you can share the information so that they can access that later. Looking forward to a wonderful discussion, and back to you, Dr. Russell.
Thank you very much, Derek and Mary. Very important to note here, I want to welcome, we have participants from all over the world that are here with us today, right? Let me also acknowledge one of our members, committee members, Dr. Lincoln Lopez Ferreira from Brazil, Dr. Deborah also from Brazil, and we have, as Mary said, welcome to Professor Marco Safety, and I'll introduce him more. He's going to be one of the panelists here. We have, I wanted to recognize or acknowledge Jasna from Croatia, and Professor Shabir from Amanullah from Canada, and several others from who are Arun Mehra and Annabelle.
This is here.
And yes, Des Cahill from Australia, who does from RMIT University, who does the executive summary, which is on the web. You'll have every webinar has a summary which Professor Des Cahill takes us through. So today we will, oh, just a moment, 1 minute. Hello, Alvin, we have a,
Dr. Russell, you're muted. You're muted.
sorry about that. That was Dr. Alvin Chan from Hong Kong. Alvin, you've started, Derek will be assisting you. So yes, that's Dr. Alvin Chan, one of our very distinguished panelists who's from Hong Kong, who will be joining us. He's just having some difficulties. So today we have, as I said, this we're going to have two presentations followed by this our usual discussion with this panel, a very distinguished panel that we have. We have today distinguished panelists from United States, USA, from India, from Brazil, from Kenya, from Hong Kong, and of course from South Africa, where he was supposed to join us a little late. But that's going to be our second part of the discussion. So let's start with this interesting presentation. We got our first presentation is going to be by Dr. Monica Vasudev, and it's going to be our shot at a brighter future. Dr. Monica Vasudev graduated from McMaster in Canada and then pursued a medical degree in Bangalore in India, and she completed a residency in internal medicine and a fellowship in allergy and clinical immunology from the Medical College of Wisconsin, where she's continued to be a faculty. And she's also served as the program director for the Infusion Center and joined the Aurora Health, where she continues to work as a clinician. And during a time, she's contributed to our very famous Dr. K.K. Agarwal, his journal and so forth. So Dr. Monica has been here before, and she has been giving to the CMAO, that's a confederation of, just like Lincoln's confederation. Lincoln is the president of the Confederation of Medical Associations of Latin America and Caribbean. And of course, we have the Confederation of Medical Associations of Asia and Oceania. And Professor K.K. Agarwal that was the president. And Monica has been presenting regularly in part of that of CMAO. So over to you, Monica. We have also Dr. Nandita, who's going to speak after that, but I think she hasn't yet joined. Is that right, Derek?
She's joined, Dr. Russell.
She's there.
She's joined. She is there. Yeah.
Then I'll introduce Nandita. She's going to be the next speaker. Okay, over to you, Monica.
Good morning and good evening. Thank you again for the opportunity to speak today. Thank you, Dr. D'Souza, Dr. Matthew, and Dr. D'Souza. It is definitely a privilege to be among all of you today. We continue to talk about vaccines because it remains forefront in our approach to utilizing the scientific resources and knowledges that we have to be able to get out of the pandemic that has affected us so dramatically, drastically, and unprecedentedly since its onset. I'll begin to share my screen. I hope you can all see this.
Yes, we can.
So this really is our shot to a better future, the world of vaccines. And today I'd like to summarize what I'd be talking about. I'll go through a few vaccine basics, such as the spike protein, immunity, what are the available vaccines, its efficacy, and vaccination rates pretty quickly. This is information that has been available for quite some time now as our vaccinations have been available. We'll talk about booster doses, which has been definitely in the news in the past several weeks, mandates, vaccines in children, equitable distribution, and future directions, not only with the vaccine, but other directions in our approach to this pandemic. I like this cartoon because there's a lot of questions about how does a vaccine work and what are we really looking for. When the vaccines became available, the messaging was get your vaccine and 2 weeks later, give your grandmother a hug. We know that vaccines are beneficial in terms of what the outcomes are. We're trying to tell those that the vaccine provides your immunity the strength to be able to fight the infection when you get it. So first, your body makes a bunch of antibodies to fight off the virus. Let's call them archers. You get sick. After about 4 weeks, those archers start to disintegrate. So we know that immunity from an infection is supposed to dissipate, but never fear, if you have a vaccine, the vaccine has also been silently training your body to make better archers. And so these new super archers defend against severe disease for years. It's simplified, but I like it because it does explain how vaccines work. I like to show this diagram because everybody is familiar of what the spike protein is. And the spike protein is a complex structure that has something known as the receptor binding domain, or the RBD. And this is the dark green, forest green structure that's on the top, to which your antibodies are binding with a greatest efficacy. But there are other components of the spike protein that are bound by antibodies, including the N-terminal domain and the S2 subunit antibody. And I just show you this because when you do read primary research papers regarding antibody production, these are the different parts of the spike protein that are being addressed. I'd like to quickly move on to immunity and why we talk about vaccinations being necessary despite having a history of prior infection, something known as hybrid vigor immunity. If you look at this diagram showing you various heights of trees representing the immunity that is a result of either natural infection, vaccine, or a combination of both. In the first, you see a tree showing natural immunity, where the different colored components within the tree represent memory B cells, antibodies, CD4 T cells, or CD8 T cells. You get sick and you will develop natural immunity. If you get a vaccine, however, you will develop a little bit more immunity. I'd like to qualify that statement a little bit by saying that natural immunity is variable. You can get a little bit of immunity or a lot of immunity. But by and large, with vaccine immunity, the immunity is strong and it's homogeneous. What happens if you had gotten sick earlier and then you followed it by a vaccine? What you then get is what's known as hybrid immunity, where the vaccine and natural immunity is 25 to 100 times more antibody responses that are driven by both B cells and CD4 T cells. That gives you that much more immunity against the virus. Obviously, there's a lot of things at play. What is the virus that you were fighting? What was the state of your immune status when you got sick, whether or not you were on immunosuppressive therapy? But this is why we think of using vaccines in those who have been infected. I had patients earlier on in the pandemic who were in the healthcare profession who met the 1A criteria for receiving vaccines in late December, early January last year. And they would come to my clinic and they would say, I don't think I need the vaccine. We should save it for other people because I already got sick. I already had a positive COVID test. I don't need this vaccine. And everybody needs a vaccine. So this is another diagram or explanation of this concept of hybrid vigor immunity or super immunity. And this is, again, a summary of the same thing I just said, that some people mount an extraordinary powerful immune response against SARS-CoV-2. However, if you get a hybrid approach with infected with coronavirus and then followed up with immunization, we see that that super immunity can be extended to a greater number of people. So what is our vaccine platforms? This is just a refresher. I really like this slide because it gives in one diagram the multiple different vaccines that are available with names that may be familiar in the area that you are from. We have vaccines that are currently DNA-based. They insert the synthetic DNA of viral genes into small molecule called plasmids, and they go into the body, and then they produce the protein to which you develop the antibody responses. The RNA vaccines is the one that's gotten the most press, the studies have been most done on this, and that are the Moderna and the Pfizer vaccines. And these are the two that we have available in the United States. You have the inactivated vaccines, which are inactivation of the whole virus and it's killed with chemicals, and that is the Sinopharm Sinovac. Viral vector vaccines, where they insert a gene for a viral protein into another. This is your AstraZeneca that is worldwide. You have the Johnson & Johnson that we have here in the United States. And then you have additional companies that were making viral vector vaccines. You have the subunit vaccine, you have the Clover from China, you have the Novavax that has undergone some of the initial trials and we are waiting for additional information. And then you have the live attenuated vaccines. I understand that this vaccine platform may not be complete with what we know today, but I believe that this is one of the best diagrams to summarize the different types of vaccines that we have and providing you with the trade names that we are familiar with or the company names that we are familiar with related to these vaccines. What do we have that's being developed in the landscape? This diagram was seen on the internet from February, September the 24th, about a week ago. The number of vaccines in clinical development at that point was 121, 194 were in preclinical development stage. As you can see from that prior slide with the vaccine refresher, there's different platforms. And here you can see the additional vaccine platforms that have been added, including viral vector with antigen presenting cell and viral vector with viral antigen presenting cell as well. There are the most number of vaccines or candidates in clinical phase, which are the protein subunit that belongs to the Novavax and the Clover that I showed you earlier. And if you look at how these vaccines are being developed, there's one vaccine or 19 vaccines that are given on one day. Those that require 2 doses that are 14 days apart, 21 or 28 days apart are being developed. Those that require 3 doses, that's one vaccine. And the majority of these vaccines are being developed by intramuscular route of administration. So we are planning to see a very large breadth of vaccines that will become available in the near future. How many people are vaccinated as of September 29th? You can see here in the dark green, those who are fully vaccinated, those in the light green as being partially vaccinated, and you can have a range of anywhere from less than 1% up to 93% of a country's population that is vaccinated. You can see the United States at this point is 64% having either completely or partially vaccinated of its population. This is a demonstration or a slide of how efficacious the vaccines are. There's multiple examples that can be used. I chose this example. This is a slide depicting the age-adjusted weekly COVID-19 hospitalization rates. So we are looking at hospitalization rates among adults, 18 to 49 years in the first panel, those between 50 and 64 years in the middle panel, and those that are greater than 65s. And they're looking between the weeks of January 24th, and the first date here on the graph is January 30th, all the way up to July 17th from COVIDNet, and the last date that you're seeing here on the graph is June 30th. What you are seeing here are those who are vaccinated, which is in the green line at the bottom of these graphs, and then those that are blue that are those who are unvaccinated. And what you can see are numbers of 13-fold, 22-fold, and 23-fold higher hospitalization rates among different age groups. What you are seeing is a reflection of the fact of their social distancing and choice for activities in these different age groups, resulting in higher admission rates. So we know that this is effective. This is a preprint that was published, or sorry, that was released on the internet recently, and I saw this on September 30th. What you are seeing here is a hazard ratio of hospitalization on the left for different variants. We see the largest hazard ratio for hospitalization is around 3 for gamma versus close to 1 for epsilon. So we know that there is a difference in the risk for hospitalization depending on the variant that you have caught. Now let's look at the role of immunizations based on variants. This is going to be seen in the right graph. You see the hospitalization hazard ratio as being depicted with 1 from the bottom one. This is your reference. Those who received Delta, which is the teal colored in the top bar, if they received an immunization in the 21 days out from their complete dose 1 of their immunization, that you can see that the hazard ratio has dropped from around 2.5 to less than 1. With gamma, the hazard ratio here in this particular scenario decreased from 3.5 to close to 1. For the alpha variant, the hazard ratio for hospitalization has dropped from close to 1 to less than 1. So not only do immunizations work, but immunizations have been found to work against the major variants. And this is, I think, the first study that I saw that looked specifically at different variants and the effect of immunization. What do we know about infection? So that was hospitalization, and this is infection. And we can see what I'm showing you with this diagram is just kind of a segue into my discussion about boosters. But as you can see across time and across multiple studies looking at different immunizations, you can see that the vaccine effectiveness can decrease in terms of risk for infection in those who are 18 and older as time progresses. February, you can see that you've got a vaccine effectiveness between 90 and 100. And by July, you now have a vaccine effectiveness that is ranging between 40 to 80%. So the booster, this has been a very, very big conversation because we are many months out now from when the initial administration of vaccines occurred. And we have information regarding the Pfizer-BioNTech vaccination. So where did we get this information on, and where did this conversation about booster doses come? So this was done, this was information that came from a study done in Israel. And what they looked at is those who were at least 12 days after the booster dose. They found that the rate of confirmed infection was lower in those in the booster group than those in the non-booster group by a factor of 11.3. The rate of severe illness was lower by a factor of 19.5. And in a secondary analysis, the rate of confirmed infection was at least 12 days after vaccination was lower than the rate 4 to 6 days later by a factor of 5.4. So we are seeing here on multiple areas of measurement that the vaccine booster was beneficial in this study. And this is the diagram that came with that publication, the New England Journal of Medicine. What this diagram shows you is the factor reduction in confirmed infection rates. So you are looking at these bars, looking at how much have you reduced your rate of infection. Those who did not receive the booster are this dotted line across the bottom. And if you've gotten the booster, what is your factor reduction in reducing infection? You can see that starting around days 7 or 8, all the way up to 25, that there is a reduction in confirmed infection cases. They didn't extend it beyond 25 days because their error bars became much larger, but this at least shows you that there is a reduction in infection in those who've received the booster. This was published by the CDC regarding the vaccine effectiveness against COVID-19 associated hospitalization in adults who do not have any immunocompromising conditions by vaccine products. So you can see Moderna, you can see Pfizer, BioNTech, and you can see the Johnson & Johnson. What you can see here, and what I found very striking, is that 14 to 120 days after full vaccination, the vaccine effectiveness was 91%. However, if you were greater than 120 days after full vaccination, the vaccine effectiveness dropped 14% to 77%. You are starting to see a decrease in the vaccine effectiveness after 120 days. I believe this to be compelling. What about severe illness? This is also from the CDC. This is looking at those who are 60 and older, those who've received the booster dose. And what you see here is there's an adjusted rate ratio of 19.5 in those preventing severe illness in those who received the booster dose. If you see in the non-booster dose, you have 294 cases, and in the booster dose, you only had 29 cases. There was a 20-fold benefit, and this can affect 1.1 million people over the age of 60 in the United States. So what happened? All this information was released. People started talking about the boosters. And I wanted to give you a little bit of a timeline of the discussion that had happened, because this was very interesting to follow.
Right. Yeah.
On the 17th of September, the FDA Advisory Committee, so this was an advisory committee to the FDA. This is the vaccine.
I honestly don't know what else to give this guy, because he's already had morphine.
So the vaccine-related Biological Products Advisory Committee on booster dose of the Pfizer-BioNTech COVID vaccine recommended against booster doses for 16 and older. So they did not think that this was recommended for everybody 16 and older to receive the booster. So that was voted 16-2. How about those who were 65 and older? This particular committee said that those that were judged to be high risk of COVID-19 6 months after the initial vaccine should receive it. And this was a unanimous vote in favor of this. And this is pretty much what we're seeing across the world as well. Healthcare workers and others at high risk for occupational exposure should receive this as well. This was, again, the VRBPAC committee, and they were currently evaluating data on 1 million who had already received the booster dose in the US at that point. So then what happened? So on September 26th, the FDA authorizes booster dose of Pfizer-BioNTech COVID-19 vaccine for certain populations, those that are 65 and older, those 18 and 64 with high risk of severe COVID-19, and then those who are 18 through 64 that were institutionalized or had occupational exposure that put them at high risk. Then on September 23rd, the CDC Advisory Committee on Immunization Practices voted unanimously, again, for 65 and older in long-term care facilities to receive the booster dose. They voted majority for those between 50 and 64 with certain high-risk conditions. They closely voted for a booster dose between 18 and 49 with underlying medical conditions. So here they broke down the age groups from 50 to 64 and 18 to 49. And surprisingly, they voted against a booster dose for people age 18 to 64 who are at risk of COVID-19 due to their occupation or living condition. So this was in contrast to the earlier FDA advisory group and the FDA. Then on September 24th, the CDC director, Rochelle Walensky, overruled the panel and said people at risk of COVID-19 because of their job should also be eligible for a booster. In terms of the data that the CDC had looked at and why they made those recommendations, those are available online if you'd like to look at those in a little bit more detail. So we kind of had a little bit of an inconsistency in how the messaging was coming across, which I think has been, because I've gotten a lot of questions regarding this from patients, friends, and colleagues, and this is what had happened. So the Biden administration originally said, you know what, all Americans age 16 and older should get the booster. The FDA advisory group is showing 65 and older underlying medical conditions and those working in high-risk jobs. The FDA said the same thing. The CDC advisory group then said, okay to the Americans 65 and older and those with underlying medical conditions, but no to people working in high-risk jobs. And yet the final and definitive CDC recommendation was then to include all those groups. So I know that the messaging was a little complicated this past week, and I wanted to summarize that for you. That was a Pfizer-BioNTech. What about Moderna? On September 28th, this was in the news that the FDA was leaning towards authorizing a Rna Virus at a half dose. And what I've heard as to why they're recommending a half dose, they felt that that was effective and it would be associated with less side effects. Those who received Moderna or know those who received Moderna are aware that this can be associated with significant side effects, especially after that second dose, whether it be fever, myalgias, or fatigue. What about Johnson & Johnson? This was also released as a press release from August 25th from the Johnson & Johnson that they had data to support its single-shot COVID-19 vaccine. This was a graphic that I created based on an article that I had read, and I don't believe that this is complete by any way. These are countries that have booster doses that are available for those that are 65 and older, with or without the inclusion of healthcare workers. Obviously, this list will be a lot larger as days go by, but I just wanted to show you that what we are experiencing or what we've gone through in the United States is not new. There are many countries that have already been implementing this. How many people have been vaccinated? This is data from October 2nd, showing you that 2.6% of the total fully vaccinated people have received a booster dose. And if you break that down and look at different populations, you see that those who are over the age of 18 are 2.7, those who are over the age of 50 are 4.3, and those who are over the age of 65 are 6.5%. So at this particular time, those who are 65 and older are the largest population that have received the booster dose. And those were the numbers that I was reading. Vaccine mandates. So vaccine mandates, I'd like to switch over now and talk about this topic, because this has also been a very, very important topic that is going to have far-reaching implications to society and how we move forward in our approach to pandemics. You can see here that vaccine mandates are not new. So George Washington and the Continental Army, they faced a threat that was deadlier than the British in the first years of the Revolutionary War. And that was smallpox. The frequent outbreaks and the weariness to inoculation, not wanting to get vaccinated, made the troops very susceptible to disease. So when Washington saw that after heavy losses in Boston and in Quebec, he implemented the first mass vaccination in American history. So what we are going through today is nothing new, maybe new in our lifetimes, but definitely not new in terms of the history of medicine. And you can see here, Edward Jenner, and this is a scene in 1802 where he is inoculating frightened women, and they all think that they have, this is with the small cowpox vaccine, that they're all going to grow cow parts from their bodies. And the fear related to immunizations also is not new. What are we seeing here in the United States regarding vaccine mandates? And I just showed you a few time events. September 9th, there was new federal vaccine requirements for as many as 100 million Americans who were in a effort to curb the surging Delta variant, which has been present for many months now. He criticized the tens of millions of Americans who are not vaccinated despite months of availability and incentives. So he was frustrated and he was impatient with that messaging about the people who have not been vaccinated. On September 15th, the LA Board of Education required students 12 and older to be vaccinated against the coronavirus if they attend inpatient classes. We had schools that start in August and September here. So this was the first particular area that was requiring a mandate for those attending school. As of October 1st, not only was it the LA, but it became all of California when Governor Gavin Newsom announced a vaccine mandate for in-person instruction. So let's go a little bit into detail about what Biden's message was. Biden's message was that employers with 100 or more employees will be required to have their employees either be fully vaccinated or get tested weekly to come to work. Federal workers and employees of contractors that do business with the federal government will be required to be vaccinated. So if you have any contract with the government, you will need to be vaccinated. Those who work in Head Start programs, as well as run schools by the Department of Defense and Bureau of Indian Education, will need to be vaccinated. Basically, these are places receiving federal dollars. And workers in healthcare facilities that receive Medicare and Medicaid reimbursements. Medicare is the healthcare insurance that's provided to the elderly. So when you're 65 and older, you automatically receive Medicare, whereas Medicaid are those for the indigenous. So if you treat patients who are 65 and older or who are part of the indigenous community, they require that, that those people who receive those federal dollars to treat those patients also be vaccinated. And individuals who are applying to become lawful permanent US residents must be fully vaccinated effective October 1st. And this was announced on September 14th. So what I'm presenting to you are rapidly changing, rapidly evolving guidelines related to immunizations. This is a graphic that I created on the different companies that have implemented a vaccine mandate in the last few weeks. And these are large companies. I think United Airlines has gotten a lot of press. They allowed exemptions for their pilots, and those who were exempted actually were told that they were furloughed without pay during that time. And you can see that Lyft and Uber, public transportation, Amtrak, these are places that they're really honing down on, but then also large organizations such as Walgreens, which is our pharmacy, commercial chain, Walmart, and others brands that you can see here. Just like vaccine mandates, mask mandates are not new as well. I just want to put this slide in to show that in addition to the history of vaccine mandates, there was a lot of opposition, and nothing has been so-called immune to the opposition to these mandates. And there was a mandate against masks as well in the past. We have been trying to encourage those to get immunized for a long time with or without mandates. And this is looking at parents, encouraging parents to get their children immunized. And that was my segue into looking at immunizations in children. This is a graphic showing you the number of COVID cases that were added in the week prior to September 23rd. This was the most updated graphic that I could find. What you can see here is an increasing number of cases of children and adult, where adult cases are seen in the light blue and the child cases are seen in the dark blue. And they're pretty much paralleling each other in terms of surges. And you can see the most recent surge now that's starting since the beginning of August, and it's continued until the first week of September, just when we have Labor Day as well. And it also parallels the start of school. As you probably have been following in the news in the United States, mask mandates have been met with great opposition within the schools. Most schools are mask optional, and children are returning to school either vaccinated or not, depending on whether even they're eligible. And you can see that the cases have risen. What are the specific number for children? And you can see those numbers right here as well. In the week of September 23rd, we had 206,000 cases that were added. So let's look at the Pfizer-BioNTech vaccine in terms of children under the age of 12. We have emergency use authorization for those that are 12 and older. We have full FDA approval for those who are 18 and older for this vaccine. Now we're looking at the age group of 5 to 11. This is your kindergarten to early middle school. The adult dose of the Pfizer-BioNTech vaccine is 30 milligrams. What they studied in this group was 10 milligrams or 1/3 the dose. They included 2,200 children. They were given 2 doses 3 weeks apart. Instead of looking at the outcomes for severe disease, hospitalization, or fatality, in this particular study, in this particular age group, they assessed antibody levels as their final outcome. And what they found was a high level of neutralizing antibodies comparable to levels seen in older children who received a higher dose. And myocarditis has been a concern for those who were in the 13, 14, 15, 16 age group who received the BioNTech vaccine. And in this particular study, there was no reported cases of myocarditis. This is the Pfizer press release statement. They said it is safe and effective for those who are in kids who are 5 to 11. And this was released on Monday, September the 20th. And then on Tuesday, September 28th, they indicated that they will submit their initial data to the FDA from their pivotal trial, those who are 5 under the age of 12. So we are waiting to hear about what their final decision is. The current feeling is that we will probably hear by November as to what their final decision will be. And I know that there are people, despite the news of people who don't want the vaccine, there are a lot of people who do want this vaccine and do want their kids to be safe. How many people are vaccinated in the United States regarding at least receiving one dose? And what you're seeing here is 64.6% of the US population. This has been obtained as of September 30th. And you can see the age breakdown. And what I want to show, which I think is interesting, in those that are over 12 and older in terms of the total population, you have 75.5% of those who've received at least one dose of the immunization. And I feel that that is pretty impressive. My final topic now is going to be about vaccine equity and vaccine distribution. And I'd like to start off with a video about the COVAX for an understanding of their program.
Policy. With the largest safe and effective COVID-19 vaccines, how can we make sure they reach the people that need them most? Today, there are many vaccines in development. Most will fail. For those that could succeed, governments are under pressure to secure supplies for their populations. If governments compete for vaccines, most countries could miss out. This is not only bad for countries that cannot secure their own supplies, it's bad for us all, as no one is safe until everyone is safe. The COVAX pillar aims to ensure that every country gets fair and equitable access to eventual COVID-19 vaccines. It does this by acting as an insurance policy with the largest portfolio of vaccine candidates in the world. Wealthier countries have a greater chance of gaining access to successful vaccines. And by pooling their buying power, rather than competing against one another, they enable investment in factories. So more doses are available as soon as a vaccine becomes available. The COVAX pillar is founded on the principle of equitable access. This means any country, regardless of their ability to pay, has the same access to vaccines. By supporting the development and manufacturing of these vaccines, wealthy countries increase their chances of getting COVID-19 vaccines and ensure the rest of the world gets access too. Ending the pandemic as quickly as possible will take a global effort. We need as many doses as possible, as fast as possible, as soon as a safe and effective vaccine becomes available. 2 billion doses would be enough to vaccinate healthcare workers and other high-risk groups. If we start now, we can save hundreds of thousands of lives, not to mention trillions of dollars. It's not about one country versus another. It's about one world protected.
So that's just a brief introduction as to what we are looking for with safe vaccine and equitable distribution. So let's look at the world. I showed you American data, how much of the world is vaccinated. And these are those who receive full vaccination. I'm not talking about partial, I'm talking about full. Those who've received the 2 doses and feel that they're protected. And you can see by no means have we had equitable distribution of vaccine or access to this. We see that the dose distribution, this is by different vaccine platforms in different countries based on income. The high income countries have received most of the vaccines, and you can see that they receive the bulk of the mRNA vaccines that are found in the orange. You have the upper middle countries, the lower middle countries, the low income countries, and then you have COVAX, which is the program that I was just showing you that was trying to distribute these vaccines. This diagram I did see in August, so this may have changed in the past month, so I apologize if this is not the most up to date, but I wanted to just give you an idea that there is unequal distribution and even unequal distribution of the types of vaccines, which we are all aware of. So So what did Biden say? This was September 22nd. And what he did was he called for global shared targets to vaccinate 70% of the world's population across all income brackets by September of 2022. And that would mean purchasing vaccine doses and then sending it to other countries. There's a lot of information that's present about this online, and I think we just need to wait to see more as to how the different countries are being participating, how many doses they're buying, and where are those doses actually going. I'd like to end by talking about future directions and broadening this beyond just vaccines. We need to really work hard combating disinformation, whether or not we do that on an individual basis with those patients that we treat, our colleagues that we work with, the society that we live in. We need to really call out when we see misinformation. In terms of equitable access, we have seen that there have been activists that have been protesting our current administration. There have been people that have been protesting right in front of Moderna in this past week, making Moderna available in more countries, looking for promising new vaccines from, there's one in China, the Clover Biopharmaceuticals, the one that I highlighted earlier. There was news in the past week about getting vaccines to rural areas in South Africa and two coastal areas, that they had vans, they had buses, they brought patients to the vaccines, they took the vaccines to the people. We really have to reduce our barriers in terms of our access to vaccines to be able to reach these rural areas. We're still waiting to hear about booster doses for Moderna and J&J. And the ethics behind vaccine mandates. This is examples of beneficence, non-maleficence. Where are we drawing the line? Why is it that we got to the point of mandates? And now that we have mandates, what are the ethics that go behind it? We have seen that with the final approval of the Pfizer-BioNTech, that there was a lot more, I think, interest in getting these mandates, and as well as understanding that timing was critical, and that if we did not race with the immunization and achieving herd immunity, especially with a high R0 factor with the Delta variant, their ability to transmit the infection to other people, and in the setting of waning immunity, that this is why vaccine mandates came about. What about COVID and pregnant people? We know that there's been a much stronger recommendation for vaccination in those who are pregnant, those who are lactating, those who are preconceptual. I think we received the most strongest recommendation in the past week. Making sure those who have HIV are not losing access to their ability to receive their care because of the pandemic. There have been new reports of new viruses, of studies in bats in China and Laos that show that Southeast Asia is a hotspot for potentially dangerous viruses similar to SARS-CoV-2. We now, the role of community health workers, how do we get community health outwards available and out to get equitable distribution, even if you do have vaccine doses? How do you even get equitable distribution within your own communities? We have monoclonal antibodies where we're seeing more positive data, and we're looking for calls for affordability and access. We know that this is very expensive. There's been new reports of a new COVID pill that's available. And then protecting our children, especially when our vaccines are not available to all age groups, and having masks available for them. Again, I think our way of addressing the pandemics is to use a Swiss cheese model, where we really need to look at different layers. And it's not just one layer that is going to be the one thing that we have to focus on, which is a vaccine. That's actually the last thing, if you can see in this diagram. There's so many things that we can do before then, and we need to work on all of these things concurrently. These are both personal and shared responsibilities, as we can see. And this, of course, is nothing new to any of you, but as I talk about vaccines, I also want to draw back and step back attention to the fact that we need to be using this model. I'd like to thank you for your time, and thank you so much.
Thank you. Thank you very much, Monica. It was a wonderful presentation that brought so much of you say it's changed, but your evidence, much of the information you're given is right up to a few weeks ago. And thank you very much for that update that has been. Can I ask you, you did talk about the children from 12 to 16. The studies we have, the information you have is from the Pfizer vaccine. Is that right?
That is correct.
Yeah, and you said there was myocarditis. Is that right? Was that the only adverse event that was recorded?
So the adverse events in children can mimic those that are in adults, but the new concern that was raised specifically for this vaccine was myocarditis. When they looked back, the myocarditis was mild. It was treated with NSAIDs. Very few needed hospitalization, but it was something to consider so that in case your child did have side effects that needed to be evaluated, it could be diagnosed efficiently, and the child could be then said, no sports, take rest. And they then compared the amount of people who had myocarditis with infection versus those with vaccination. And obviously it was multiple fold less. And I apologize for not knowing those numbers right now, but that the myocarditis risk was much lower with vaccination than with infection.
Right. And was the evidence, do you have information from Moderna? Because that's also being used for 12 to 16, isn't it?
No, the Moderna is only 18 and older. The only vaccine that received EUA, emergency use authorization, was a Pfizer BioNTech. So what happened was when the children got that early EUA, we ended up saving a lot of our Pfizer doses for those populations, and the adults that came for immunization ended up getting the Moderna or the Johnson & Johnson. And now with the booster doses, they're trying to give the same dose of the same vaccine, because we do not have a strong culture of mixing and matching here. They do require that you get the same vaccine that you originally got. So if you got Pfizer BioNTech, then you will receive that as a booster.
Although in the last talk that you gave in our last webinar, you did show there was a better, the German study that brought a combination of two, giving you a better antibody.
That was the Novavax data that I had shown earlier. And I know that there's a lot of Novavax studies. That's a protein subunit vaccine. And I'm waiting to see whether or not there are additional data available. There's been nothing new that I have seen in terms of compelling new data compared to what had been published in June. And that was the studies that were done in the US and Mexico. I know that there's multiple worldwide Novavax studies being done right now. So I'm waiting for those results to come out.
Thank you very much, Monica, but we'll have in the panel discussion, we'll hear more about this. Now, can I go on to introduce our next presentation? Is going to be, before we go into our panel discussion, will be from Dr. Nandita Hazara. Now, Dr. Nandita Hazara is also someone who has spoken at and been on the panel at this on this platform of panel discussion. Dr. Nandita Hazara is a neurovirologist and from Pune, and today she is going to speak on SARS-CoV-2. Do mutations matter?
Thank you, Dr. Russell. My only request is if, Derek, could you please stop sharing, because I have a lot of movement in my slides and my internet is a lot better. So I'll just take the slide share on, please. Will that be all right?
Okay. Yes. Derek?
I'll just make you co-host. Just give me a second.
Yeah, waiting.
Done. Please try.
So I think you can see my slides.
Yes, that's visible. That's full screen. Yeah, thank you.
All right. So firstly, thank you for having me here. I think from March 20, I have really felt the need to be part of a community which was anxious and scared about the SARS-CoV-2. I think the real role of a virologist came in when we had no clue about what was hitting us and what was happening. And being a person who constantly believes in, helping people to understand the scope of immunization, the scope of practices which are required for preventing SARS-CoV-2, I want to thank Dr. Russell for having me on this panel and helping me to just do that. So I think Monica has alluded to vaccines and masking in a lot of detail. So what I'm just going to do is go absolutely to brass tacks. And I saw a lot of questions there on the panel, which I felt, actually related to basic facts about the virus and basic immunology. So I'm going to try and cover that as I speak. So as you all know, RNA viruses, SARS-CoV-2 is an RNA virus. We have had numerous RNA viruses emerging in the past 2 decades. And mutations are constantly happening in RNA viruses. And the best part about these viruses is that they have a high yield of virus per cell and have a short replication time. And they can exist as complex and dynamic mutant swarms. In fact, that is what is the concern now, because you find that HIV virus exists as quasi-species, and we are concerned that there may be, in fact, there are reports of the SARS-CoV-2 virus 2 existing in different templates inside the cell, resulting in combinations of these, and that is where these kind of mutants are coming on from. To ensure survival, RNA viruses exploit all known mechanisms of genetic variation and complexity. In fact, they are an excellent, they behave very, very well. They are like a good child when it comes to absolutely virus naive population. And that's what you must have seen over the initial year before the antibodies had developed and patients had actually developed herd immunity. And now what you're seeing is the errant child, where suddenly you find these viruses coming up with a host of mutations. And because of this lack of selection pressure, which was there earlier, we didn't see much variety. In fact, whatever was happening in the US was happening in Italy, was happening in Germany, was happening in South Korea. And we actually knew that when India gets hit, how we have to handle SARS-CoV-2. But that didn't happen during the second wave, which hit India in April. And we kind of thought that things will be the same and that India is never going to have the second wave because we had already started our immunization and things were in place. But it wasn't so, because the virus had now started mutating. It had started changing. And what happens with viruses is that large population passages result in rapid fitness gains, and they may come in contact with new potential hosts. And that is the general concern, because they can even host jump. Now, this is just to show you the virus morphology, very old, very common knowledge, and but important to reiterate to, because mutations can occur in any of these parts. They could happen in the envelope, in the nucleocapsid protein, in the viral RNA. They could happen in the spike protein as well as the membrane protein. Right? And the membrane protein is what is important and necessary for fusion of the virus. And we'll just go a bit into that. Spike protein is basically important for virus entry, with the S1 subunit binding to the host cell receptors and the S2 subunit responsible for fusion. In fact, it's a very interesting way that the virus actually manages this. This slide I borrowed from Dr. Rna Stewart's presentation. She spoke about the non-structural and the structural proteins and how the complete SARS-CoV-2 genome could have variations because of mutants or mutations in either of them. The common associations we speak about, I'll just rush through this: infectiousness, contagiousness, and transmissibility. So infectiousness is basically the amount of viral particles which are needed to cause an infection. Contagiousness is the infectious virus per the plaque forming unit ratio. That means the amount of virus which is there divided by the actual virus which is able to cause plaques. And we'll talk a little bit about that during our discussion. So the number of plaque forming units of the virus basically needed to cause the disease. And transmissibility is a whole combination. It is about the infectiousness of the virus, the contagiousness of the virus, the amount of virus which is actually produced in the host. That means how much is replicating, how much of virus is released, its quantity, infectiousness, how stable it is able to how stable it is in the environment and how it's surviving in air, and of course, infection of the next host. So does it really reach the host, and whether masking is there, so it prevents the movement of host, or whether there is hand hygiene, so there is, fomites are being reduced in terms of infectiousness, and of course the host immunity, which I think plays a huge role. And unfortunately, there has not been much effort in studying host immunity, except for probably the antibodies, which we've seen, and we've realized that the antibodies have absolutely like kind of a minuscule role, really speaking, in terms of long-term immune responses against the virus. Now, INSAGOG and pangolin, these are basically the two initiatives which were observed, especially INSAGOG, which is the Indian SARS-CoV-2 Genomic Consortium, which was jointly established very, very early when India started seeing the pandemic by the Ministry of Health and Family Welfare, the Department of Biotechnology, CSIR, and the ICMR to assess the SARS-CoV-2 virus variants from Indian patients. And there has been a continuous genomic and epidemiological surveillance, because I remember at the beginning of the second pandemic, when I called up NIV and spoke to Dr. Varsha and asking her whether we could send in some of our isolates from VTM samples which are tested positive. And she said, but the Delta variant is already here. So I asked her, can we send them for Delta? And she said, no, it's already here. So I must say that I have been amazed at the way the Indian government and the Indian initiative has been in place in India this particular pandemic. We saw a whole lot of mucormycosis, but again, there were reports coming across from all over the country, and we were actually sharing information as to what to do and how to do it. So for me as a virologist and of course, mycologist, it's been an amazing experience to help the community, get better. Pangolin, basically, it's the phylogenetic assignment of named global outbreak lineages, and it's a set of sequences close to each other. And that is what we generally follow to determine the mutants or the variants which are there. You have the variants of interest, variants of concern, and the variants of high consequence. Variants of interest before they really start creating issues. Variants of concern for which there is clear evidence indicating a significant impact on transmissibility and severity. And variants of high consequence where there is evidence that whatever medical countermeasures you do, they're not going to be effective as regards. And this is what we saw in the wave 2 in India early this year. So if you really have a relook at the pathogenesis and immune response, and I'm going to go over it a little quickly, but I think it's very, very important if we really have to understand what the vaccine is going to do, what masking is going to do to help us as regards containing the viral infection. So if this is a person who is basically going to be infected by a SARS-CoV-2 with all these proteins, and you have the RNA inside and the nucleocapsid protein surrounding it, the E protein, the spike protein, and the M protein being the membrane or the matrix protein. So what it basically needs to do is enter it through ACE2 receptor. Once it enters, it's going to form this vesicle. Vesicle is going to fuse, and the virus basically is very intelligent. It kind of converts this cell into its own home and is able to actually multiply, make more RNA copies, and actually bud out of the cell, as you can see here, and get into the system to infect more cells. Now, this particular virus may be ingested by an antigen-presenting cell, which is usually an immature dendritic cell. Once this immature dendritic cell ingests the virus, it is going to be no longer immature. It's going to be a mature dendritic cell. It's going to help a T helper cell. And this is going to then either convert into a cytotoxic cell, or the T helper cell is going to basically help the B cell to produce antibodies. And these antibodies, like Monica specifically mentioned, they could be due to the enter protein, it could be to the spike protein, and various other proteins or the RBD, which are present on the surface of the virus. The role of antibodies really is in prevention of infection. So when we were talking about convalescent plasma, it is basically only effective when the virus is present outside before it causes infection. Once the virus has caused infection and is inside the cell, unfortunately, there are reports of the virus being able to transmit from one cell to another by the method of membrane fusion. So once that happens, the virus does not even need to come out to cause infection. And that is why we are seeing a whole lot of infection of endothelial cells, of neurons, etc., which my work has completely been, my PhD work has completely been on measles. And we see the similar behavior in the measles virus, which is also an RNA virus. And this virus behaves quite similarly. So if the cytotoxic cells are produced, they basically completely destroy the infected cells. And if there are B cells which are being stimulated, the antibodies are what are going to act. And this is exactly where the convalescent plasma or even the monoclonal antibodies act. They act on the whole virus. So the story is all about receptors, and though we spoke about, infection of the lung and a little bit of pharyngitis and a little bit of diarrhea in initial days, as you can see, the complete panel of the tissues and organs which can be infected by the virus, and these various epithelial cells which have the receptors. And you can see very clearly in this diagram that whether it is the ACE2 receptor or the TMPRSS2, they can both be present or either could be present, resulting in the infection of the potential target cell. Now, a little bit of basic virology. I'm going to try and make it as simple as possible. So every virus has to attach. So if you understand that a virus has to attach on an epithelial or an endothelial cell, you know that the masking is important, or making sure your hand hygiene is important. And once the virus basically comes and attaches onto the cell, it is going to, and the receptor is the ACE2 receptor. It is either going to get into an early endosome by endocytosis, and the virus particles are going to be cleaved, or what is going to happen is it's going to fuse at the plasma membrane, and this is where the human TMPRSS2 acts. And following this, once either of them happens, there is uncoating. So you have the attachment, which is A, the P, which is the penetration, the U, which is the uncoating. And once the uncoating of the virus happens, it is this viral RNA which is going to be responsible for production of more parts of the virus. Now, the virus basically has two parts, non-structural and structural. So these structural proteins basically compose the envelope, the spike, the nuclear capsid, the membrane, and the non-structural are the enzymes, which the virus needs to keep multiplying and make more of itself. And both of these, basically, you will see that are then finally packaged with the help of the Golgi bodies of the host cell. And then finally, it results in the release of these viral particles into the environment. So the constellation of mutations that we have seen, whether it is the B.1.17, which was the alpha, or now we are seeing the B, excuse me, 0.1.617.2, which is a delta plus. We are seeing these, and the complete difference of these mutants has resulted in different ways of infection of the individuals, different clinical manifestations. We have seen in the Delta Plus, patients were not giving us that 7-day leeway period. Initially, it was at classic 7-day first symptoms, 7th day, 8th day, 9th day, keep an observation of the pulse oximetry, look for symptoms, see if the patient is deteriorating, and immediately shift to hospital. Sorry, second wave is not like that at all. We actually found that patients did not give us any time. Within 2 days of the first infection or history of contact, they were in hospital and on oxygen. And that is why India battled this huge problem of shortage of oxygen across the country in wherever you could speak of it. Now, since we've spoken about all the proteins, and since it is the spike protein, which is the most important protein against which the antibodies are going to act, and if you note, most of the vaccines that Monica has spoken about, has alluded to, she has discussed the predominantly, though she's mentioned hybrid memory, it is about antibodies. And since the spike protein is the most important protein, if attached to the antibody, or if prevented, to attach by the antibody, results in lack of infection or reduced infection. So we talk about the spike protein. Now, the spike protein has mutations that occur, basically could be either deletions, additions, or they could be substitutions. And when we talk about substitutions, these are the amino acids which can be substituted for another. And that is why we have these, the real story of the S protein, where we have the spike protein, which is nothing but a trimer, binding onto an ACE protein, which is on the host cell membrane. And this is the RBD, or the binding domain, basically, the receptor binding domain to which the ACE protein attaches. So the S protein is a trimer, and you can see that it is completely bound up here with the S1 and the S2. And here you can see the fusion protein and the N-terminal proteins. And really, if you look at it, this is what it looks like. And this was a beautiful image that I just had to share, because you can see that multiple of these are present on the SARS-CoV-2 virus. The complete S spike protein is a 1273 amino acid long chain. And the two main areas where these mutations have been found are in the receptor binding domain, which extend from about 314 to 590 amino acids, and the purine cleavage site, which is around the 700th location. And if you see, the D614G has been constant through all of these mutations. And if you look at the alpha, these are the various chains that I'm just bringing up. And these are the various chains which have been showing these mutations. So if we look at the site of mutations in the spike protein, it could be the D614G, that means a replacement of glycine at the 614 location. It could be in the N-terminus S1 subunit. It could be in the receptor binding domain, in the furin cleavage site, or the C-terminus. And the D614G, it basically, minute the mutation occurred, it was observed that it enhanced the functional S protein assembly. So the virus basically has to multiply. The parts, the structural proteins and non-structural proteins have to form in the cytoplasm. And then the virus has to assemble before it is released. And for that assembly, you require the S protein. And this S protein basically is, and the envelope protein, and the increased infectivity and stability of the virus was observed with the D614G mutation. And in fact, higher viral loads were also observed. Now, as regards the enter S1 subunit, it is required for the virus receptor binding of the SARS-CoV-2. And what was basically observed was deletion or creation of this amino acid, deletion of the AA at 69 and 70, and substitution. So there were no real, new amino acids being put in. And what was observed in the behavior of the variant was alteration in the antigenicity, conformational change in the spike protein. So obviously, the minute there's a conformational change in the spike protein, its binding to the antibodies reduces, and sometimes it may bind better with the ACE protein, so ACE2, so the receptor. So this is basically all the significance that was occurring with the N-terminus S1 subunit modifications. The RBD is what has to stand up. So if you note, this is the spike protein, which is present on the surface of the virus. The S1 actually protects the S2 protein. So the S1 has the RBD. RBD attaches to the ACE2 receptor. This binds directly to the ACE2 receptors, and the mutations basically result in virus fitness and antigenicity. So if there's a single mutation, there's increased immune escape. And if there are 3 RBD mutations, a high conformational changes induced. And this conformational change, again, like I told you, can have various manifestations downstream. Now, the pathogenicity of variants, whether it was the alpha, beta, gamma, iota, and epsilon, again, it was seen that they had an increased binding capacity to the human ACE2 receptors. They had increased resistance to the SARS-CoV-2 neutralizing antibodies. Just a brief segue here, just to understand, neutralizing antibodies are the only antibodies that can actually neutralize virus. Whether the antibodies are immunoglobulin G, immunoglobulin M, or immunoglobulin A, unless they attach to the virus, bind it, and remove it from circulation, they are not called neutralizing antibodies. So neutralizing antibody is a function of antibodies. And when we talk about detection of antibodies such as IgG, IgM, IgA in the serum sample, unless they are neutralizing, they are really of no relevance to removal of the virus from the serum or from the blood. Hence, whatever studies are being done on vaccine, post-vaccination, it is important that the studies be mentioned as neutralizing antibodies. And that is when they're really relevant. Because the other antibodies, as we have seen, they may last for about 4 months, maybe up to 6 months, but whether they're going to prevent a recurrence of infection, it's been shown that not really so. Okay. So this was it. And this is the furin cleavage site. So the furin cleavage site is basically essential for membrane fusion. And the loss of structure function can have a major negative impact, in fact, on the viral pathogenicity. And again, these are basically substitutions, and they could, nothing much has been known as yet, whether it enhances or decreases viral infectivity. And there is a lot of unknown significance about this. And finally, the C-terminal S2 subunit, again, which is the part which actually goes into, so you have the C-terminal part which actually goes, it's not the transmembrane part, it is the cytoplasmic tail which goes into the virus. And this again has multiple mutations of unknown significance. So I'll end here. I've kept it short, brief. what I'd say is vaccinate, 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 encourage vaccination. Vaccination does not mean complete resolution of symptoms if infected, and in case vaccinated does not mean you're going to be free from disease. You're taking an intramuscular shot, and your virus enters from the oral mucosa or the nasal mucosa or the mucosa of the eye. So it is not likely to prevent infection. The only thing it surely does is reduce the morbidity of infection. There are reports, very few reports in India as well, where we have had mortality in vaccinees who have contracted the disease. Here again, it is important to understand that it is not only the vaccine which is preventing the disease, it is also the dose, the viral load, the dose of the virus which was ingested, or inhaled. It is the immune response of the individual to the virus, and of course, the complete genetic makeup, which determines how the individual is finally going to behave when it comes to the as a response to the virus. So there are a whole lot of things to be really understood. In fact, I'll just bring up an interesting anecdote. When we started in March and April, and there were people, whole lot of things that were going on around in the environment, which said, inhale hot water and keep inhaling, keep steaming yourself. And I used to wonder, as a virologist, that how do I communicate, to these people that you're only in fact damaging yourself. So whenever I would find, I would get these WhatsApp forwards, and from a community, because I was looking after a whole lot of communities at that time as part of my service to community, and I would get these forwards and I would say no, and it would be forwarded from there. So just be alert, be aware, stay safe, vaccinate, encourage as many people around you to vaccinate, to mask. And there was this query about how do you, even after vaccine, we're still contracting disease. So how do you prevent disease in diabetics? So keep them safe. Keep them, restricted movement, keep them masked, keep them in an environment, not too much of physical interaction, because South Korea had seen that young adults were the ones, contracting disease, not manifesting, and then spreading the disease a lot. So you're always going to have populations like that, which are going to be asymptomatic and still spreading disease. So stay safe. Now, thank you for your time.
Thank you, Nandita. Thank you, Dr. Nandita, very much for that very interesting presentation, updating us on the mutations of the virus. So now let's go on to Professor Mary Matthew. Will take now moderate this, and I just want to introduce. We're going to add to these Professor Monica and Nandita. We have Professor Marco Safadi, who is the head of the Department of Pediatrics and also the coordinator of the postgraduate courses on health sciences at the Santa Casa di Sao Paulo School of Medical Sciences, and has been there for a long time, for 10 years, and is working as the permanent member for the advisory board on immunization practices for the Secretary of Health in the state of Sao Paulo in Brazil. He's also the chairman of the Department of Immunization for the Society of Pediatrics at Sao Paulo, and the chairman of the Department of Infectious Disease for the Brazilian Society of Pediatrics. And so welcome to Professor Marco. And then we have two others who are very distinguished colleagues of ours who've been on our panel before. One is Dr. Alvin Chan. Dr. Alvin Chan is a committee member, and he's also a pediatrician, and from the Hong Kong Medical Association, and he's also the treasurer of the Confederation of Medical Associations of Asia and Oceania. And he's going to be a panelist giving us from Hong Kong, China. And then I have Dr. Leon Ogoti from Kenya, who is an infectious disease specialist, but he is also the convener of the Public Health Consortium. And again, from the Kenyan Medical Association. So we have these joining us now, along with Professor Monica Vasudev from USA and Professor Nandita Hazara from India. So over to you, Professor Mary, to take us on to the discussion.
Thank you very much, Dr. Russell, and thank you to all our speakers. It was a wonderful presentation. I think information, education-wise, we do have students on this program, so I'm sure everyone benefited from the various presentations. May I request all the speakers and the panelists to please switch on their videos so that our participants can see you. So. Dr. Leon is there. Professor Marco, I can see you. Dr. Leon and
Alvin.
Dr. Alvin, if you could switch on your videos, that'll be good. I think.
Yes, okay. Thank you. This is Alvin from Hong Kong. I'm sorry that the camera of my computer gone out of work.
Have you shut it?
Sorry, it's okay not to see me.
No, have you shut it? Have you shut your webcam? Is it closed?
No, your camera.
Yeah.
Camera is occupied by other apps. It said so, and I don't know how to fix it. And okay. So when I tried to, it's unable to access camera. So I tried to have changed it in the settings, but it still didn't work yet. But never mind.
Okay, we can hear you. We can hear you. Dr. Leon, are you okay
Thank
with
you.
Switching on your camera? Dr. Leon? I'm not sure if he's there because both of them had internet issues. While we wait for them, I'll just before I go to Professor Marco, Dr. Monica, I think you've given such a comprehensive view on vaccine mandates and vaccinations and vaccination in children. I believe that the CDC has recommended that children below 12 years should, 2 to 12 should wear mask because they haven't really recommended vaccination for children 2 to 12.
Yes, that's correct. Please, Monica.
Oh, no, sorry. No, go ahead, please.
Professor Marco, I'll come to you. Ladies first. Okay.
Okay. So right now, the vaccination data on 5 to 11 from Pfizer BioNTech has been submitted or will be submitted to the FDA. We will expect to hear some information soon. There has been a lot of focus on this because of the surge of cases that occurred when school returned. Most of the schools have kept mask optional, and under the mask optional setting, less than half the students are wearing masks.
Yeah.
My school has, for my children, I have an 8th grader and a 10th grader, and they wear masks in indoor activities in the school, and they don't have to wear masks with outdoor sports or recess. Having said that, though, if we know that 75% of kids 12 and older have received at least 1 dose of the Pfizer BioNTech, that still provides that level of immunity in those age groups, in those grades where there is vaccination available. I do feel that, that the mandate for wearing masks in children is not going to be present or enforced. It is very difficult to keep asking a child to put the mask up. And I think that, that the vaccine is going to be the next step in terms of addressing what we can address in terms of volunteer immunization in this age group, except for, as you saw in California, where for the entire state of California, they're requiring that students who are eligible for vaccination be vaccinated to attend in-person schooling.
All right, thank you. Professor Marco, you wanted to say something? Dr. Nandita, I'll come back to you.
Sure.
Yeah, just to add, and thank you for very nice presentation, very comprehensive regarding all the topics we are discussing. But just to bring some provocative questions, and that's right, that in US and in most of the places, the only vaccine that is available for adolescents is the mRNA vaccine from Pfizer. But we do have in some places, and this is a very global forum, we also have the inactivated vaccines that are being extensively used in middle and low income countries. And we do have in Brazil and several Latin American countries, both the Sinopharm and the Sinovac vaccine. Both are inactivated vaccines. I think these vaccines have a very interesting profile of safety. A platform that we have been using for decades with other vaccines like hepatitis A, rabies, etc. And our experience so far with these inactivated vaccines regarding safety is indeed outstanding. We haven't seen any major issues with this vaccine, and some countries here in South America have already started to vaccinate children. So Chile started to vaccinate children from 6 years of age with the inactivated vaccine from Sinovac. And Argentina yesterday announced that they will start also vaccinating children with the Sinopharm vaccine. And we do have the data from China, which is not randomized control studies with these vaccine in children, but they do have an extensive phase 4 data regarding almost 6 million children that have been vaccinated in China, and they reported the safety profile of the vaccine, very reassuring safety profile. So I just want to add that maybe taking in account this risk-benefit analysis when you decide to vaccinate children, I think that this platform for children is a very interesting platform to be studied. And I think that inactivated vaccines should be an option for vaccinating children. Just to bring this point to the discussion, because I think it's provocative and an interesting point for discussion.
Yeah, Dr. Nandita, you wanted to say something.
Yeah, Dr. Marco, I think that's an excellent point that you brought across. Because the type of the vaccine that is given to induce immunity is extremely relevant. And yes, especially in pregnant women, in diabetics, in high-risk categories, yes, definitely it would be better to use an inactivated vaccine than an adenovector vaccine. What I just wanted to bring to the notice of the August gathering here, especially to add to what Monica said, masking, yes, but then so many issues about what type of mask, what type of material of mask, how the mask is to be worn, whether it is going to be worn all the time or not by children, whether they're going to take it out and exchange the mask with the others. So there are a whole lot of issues that we have to as yet handle. Thank you.
Yeah, and also matching your mask with your outfit. That's also very important.
Correct. Absolutely.
Yeah. Dr. Leon. Dr. Leon has been on this platform before. Dr. Leon, you can unmute yourself. You'll have to unmute. Yeah. Kenya and vaccines in children. How does Kenya fare?
Thank you very much. I was having a few issues earlier, but I'm happy to be here. Wow, that's a very interesting question. As far as children are concerned, we are not even close to finishing with the adults. So we are a very, very, very long way off. I think as far as complete vaccination to adults, as at today, we are barely at 1 million.
Okay.
And we are a population of close to 50 million. So I don't even think that conversation has been had anywhere.
But Dr. Leon, children are going to school in Kenya?
Yeah, absolutely. We had stopped school sometime last year, but eventually there was too much pressure because the Ministry of Education felt they were losing too much time, and there was no clear plan on how to get them back. A lot of children are in rural areas, so having discussions about online learning couldn't work. And a lot of the children are in the public education system. So that was a very big challenge. So they felt it would be better if they just went back. So they had all these regulations on, mask mandates. But I mean, that was a big challenge because the masks were generally unavailable or too expensive. And I think additionally, the issue which has been raised, how do you get the children to consistently wear masks effectively? Yeah. So that was a big issue. So as far as that is concerned, it's really a challenge, and I really don't know. Actually, it would be interesting to hear, yes, apart from the mandates and what protocols can be put in place, but what is the practicality for LMICs, for example, who cannot vaccinate, who cannot even afford to have children consistently wearing masks, because it even becomes an issue of the recycling of masks.
Yeah.
Things like those. What is the hygiene on the mask itself? So it would be really interesting to hear about the practicality of
Dr. Mary, can I answer that?
Yeah.
So basically, I feel that if you're able to test children and ensure that anyone who is throwing out the infection is kept home, that hugely reduces the chances of infecting others. This is what we have found in India. In fact, in case or good quarantine. In fact, we have been doing pool testing for batches. So you batch, you can batch at 5 or 10. We have the TrueNat or the Gene Expert, basically the machines which are used for detecting the presence of the viral RNA in clinical samples. You can pool it, and then in case a pool comes positive, you can separate them into separate tests and then do it. I feel the pooling of samples has been hugely beneficial in ensuring that when you send a person back to school or back to work, it reduces the chances of infecting others. Especially during the first wave, we found it very, very useful. Thank you.
Yeah, thank you, Dr. Nandita. Dr. Alvin, we can see you now. We can see you now. All good. Dr. Alvin is a pediatrician.
Thank you.
Dr. Alvin is a pediatrician from Hong Kong.
Yes, thank you very much again for including me in this panel discussion, meaningful webinar. And I am pleased to share with you the situation in Hong Kong. In Hong Kong, we have a population of 7.3, and overall vaccination rate is about 67%. 67% with 2 doses completed, and slightly less than 60% with, 67% with 1 dose, all right? And then about 58% with 2 doses completed. So in fact, we have plateaued in the rate of vaccination because there are lots of anti-vaxxers, and the vaccine hesitancy has some political factors inside. I think the situation is like Israel, which had achieved 60% of the vaccination of the overall population very soon after the inauguration of the mass vaccination. But then again, it plateaued in a way because it had a big population of children in Israel. And also there is the political rivalry that had driven people against vaccination in a way. So in Hong Kong, the sad thing is that of the population over 70 years of age, the vaccination rate is only shamefully less than 30%. That is the vulnerable elderly population has only a rate of 30% vaccination, and that is too dangerous for Hong Kong to open up the border like Singapore. You see, Singapore is always, a rival to Hong Kong in many places, in any cases. And so in this aspect, Singapore is very successful in that overall vaccination rate of over 80%, 82% of their population has already been vaccinated with 2 doses of Moderna or BioNTech. And then over 70 age population, their vaccination rate is over 90%, just like that of the USA that was just presented by Dr. Monica. So we admire them so much. The problem is that most of the family members, elderly people, are scared by the early reports of the side effects or the deaths related to vaccinations against COVID-19, such as those deaths in the elderly homes in Norway, and you remember at the beginning of the mass vaccination, etc., etc. And so they have to have their consent for the elderly to be vaccinated, and they did not sign the consent. And so the elderly people won't get the vaccination in that aspect. And also, the parents were so scared about the myocarditis. And so although we started off the teenage group vaccination well since May, but then as early as in July, when the reports about myocarditis in the boys receiving COVID-19, the Pfizer vaccine, most of the parents hesitated again. And so now the government had compromised that only one dose of BioNTech is required for the boys from the age of 12 to 17. And the second dose is spared for the boys. So that is something interesting in Hong Kong. Well, we are at the southern border of mainland China, you know. So has followed the policy of mainland China, that is to have zero tolerance of any cases in China and Hong Kong as well. So in order to open the border between Hong Kong and mainland China, we have to follow the policy of mainland China so that we could have made businesses with people in mainland China. You know, that is 1.4 billion people in mainland China. So that is a difficult task and difficult target to achieve, because there will be imported cases from citizens coming back from other countries, bringing with them the Delta variants, the Mu variants, and that would make the mainland people government very suspicious about the danger of people of Hong Kong going into mainland China, because for the Delta variants, they could become positive after 3 or 4 tests of negative results, you see.
Absolutely.
And they will have very, very stringent rules against people of Hong Kong and also Macau going into mainland China. And also because of the low vaccination rate in the elderly group in Hong Kong, so we still could not have the border open between Hong Kong and mainland China, not to mention other countries, of course. So Hong Kong is still an isolated small island in the world, unfortunately. So coming back to children, all right, I'm a pediatrician. So in Hong Kong, we have been fortunate that we did not find MISC or serious cases of children that infected with COVID-19, like Caucasians, Indians, or the Africans. You know, the yellow people tend to have mild asymptomatic cases in the children. And so the only 2 cases of children with MISC, that's the serious hyperimmune reaction after the COVID-19, were only one with the Russian ethnicity, second with Indian ethnicity, not with the Chinese blood. So, so that is also another reason why the parents are hesitant to let their children have vaccination, because they feel it's not risky for their children to get the infection. So we are now, on the other hand, over the border, Chinese population already got 72% in general completed 2 doses of COVID-19 vaccine. It's very, very high achieving for them. And then they still will keep the stringent border control to let no cases enter mainland. And so they would have the zero tolerance. Of course, they also learned from the sad, failure in Singapore. Just 2 weeks after they opened the border, then they have a daily confirmation, the daily cases of over 2,500, and that's scary. So China could not allow this, and same as Hong Kong government won't allow this. Although I would like to go to India, to Australia, to England, to America.
Sometime all of us would love to travel. Dr. Alban.
Yeah. So we are so isolated in Hong Kong. So the mood here in Hong Kong is not good. The economy is still bad, and we are not happy. So, but still, we are concerned about environmental protection, because in Hong Kong, we are a very careful people. 95% or more of the Chinese people in Hong Kong are masked. So we are all faithful masked, and but all with the disposable surgical masks. Okay. We are reluctant to put on those reusable masks because they very often could not have the protection we demand in the hospital or the clinics. And then we will all extrapolate to all our daily living. So anywhere we go out of our home, we will put on, a disposable mask. Okay. And then also we have all for takeaways. We have all the fast foods takeaway in those lunch boxes, dinner boxes, and those are also very often non-degradable materials, making up the straws, making up the spoons, knives, forks, and also the containers, food containers. So the environmentalists have been voicing out and have been struggling with the medical personnel. A balance between the medical protection and environmental protection. So I'd like to listen to your wise opinions, how to strike a balance between these things, because we have been they had projected a calculation that we will be using over 2 billion masks, disposable masks every year from Hong Kong, just a small, tiny island of Hong Kong. So I think perhaps we should also consider this sustainability of our world. And because we are educating our children, then we are talking about the climate change, the global warming in the country level. But this is also something that we are educating our children. So how can we find the balance? About the types of vaccine in Hong Kong, we have been cooperating with mainland China to develop the nasopharyngeal vaccine. Developing a vaccine through the nasal route, and that is a live attenuated one. And of course, it's, perhaps less vulnerable to the mutation of viruses. And then also in some parts of the world, we know that we are developing the oral route of COVID-19 vaccine. This will be good if it's for those who are afraid of vaccinations, especially when we are also testing for the safety of these COVID-19s to a vaccine to children less than 11 years old in mainland China as well. So if the vaccines could be safely given to children less than 11 years old or even less than 5 years of age, then the overall coverage might be even better than the situation now. So I would also like to ask your expert opinions, how you think about development. Thank you very much.
Thank you, Dr. Alban. I just want to go to Professor Marco. Professor Marco, you had raised your hand regarding, because I need to ask you also regarding tourism and borders, because your country has use the Sinovac vaccine. And you probably have heard there's a big row between India and UK right now, where they're not, regarding the AstraZeneca vaccine, and those who have taken those vaccines have to be quarantined and, have to have a negative PCR test. So Professor Marco, would you like to comment on that?
Yeah, well, I raised my hand just to bring some points to the what Nandita said, and also Dr. Shan, regarding the burden of disease in countries and how different they can be. And just to bring the discussion here in Brazil, so far, since the beginning of the pandemic, we have already reported 2,500 deaths in children and adolescents. These are mortality rates that are probably 10 times higher than the mortality rates. And I'm talking of mortality rates, death per million inhabitants of children.
This is unvaccinated. This is unvaccinated.
No. Unvaccinated before being vaccinated. I mean, just to highlight how different the burden of disease may be when we compare, for instance, the experience from Hong Kong, where they do not have serious cases and severe cases in children and almost no reported severe cases. That's not the reality here. We have missed cases, and we do have some high mortality rates in children when you compare to US, to UK and other European countries. So we have to have this in mind in some middle-income countries and low-income countries, that mortality rates can be high. The second point was that the idea of bringing the vaccine from mRNA for those adolescents, giving one dose, which was the decision from UK regarding the healthy adolescents. This is interesting because the dosage of the vaccine that is being used in adolescents, the 30 micrograms, is exactly the same dosage that is being used in adults. And as pediatricians working with vaccines, we know that adolescents usually they present very robust immune responses. So it's perfectly plausible that a lower dosage, once used in adolescents, would be sufficient to induce an immune response, and probably with less side effects and less risk probably of these myocarditis. The second point is that most of the cases, I probably think that more than 80% of the reported myocarditis cases associated with these mRNA vaccines were reported after the second dose. So this strategy of giving just one dose for adolescents, for healthy adolescents, and waiting for more data, waiting more time, just really to understand how the vaccines behave in those adolescents, I think it's an interesting option. And I very much appreciate the decision to use lower dosage in children below 12 years of age, as pointed out by Monica, the 10 micrograms in children, and even the 3 micrograms that they are using in infants and young children. The last point I would like to mention is what Dr. Nandita said, and I think that last week UK reported in Lancet their experiencing, comparing the effectiveness of daily testing children going to school, comparing to the quarantine option. And they proved that you can keep children in school once you are able to test them daily with the same effectiveness of doing quarantine. So I just would like to highlight that, because for us pediatricians, keeping children in school is extremely highly relevant. Yes. In some countries, this is a dramatic burden, keeping children out of school, especially in places like our places here in Latin America, in Asia, in Africa. So this is really dramatic. So once we are able to have strategies that keep children in school, like the daily testing that Dr. Nandita pointed out, I think this is very appreciated. And regarding your last point, Dr. Mary, of these travel issues, I think this is really something that I cannot understand in some points. We are seeing, for instance, now Brazil is probably one of the places in the world, I mean the high population countries, with the lowest burden now, and we are still being considered non-welcome in several countries that currently have a worse situation comparing to Brazil.
Correct.
We do have the Delta here for more than 2 months, and so far Delta here did not have the same impact as the Delta have. Maybe it's too early, but so far they did not have the same impact as they have in US and Europe. Maybe because you are accelerating vaccination now, maybe because we have the Gamma variant before circulating, maybe before we have a high seroprevalence of disease. So there are several points that we have to discuss. But I'm very skeptical regarding these first generation vaccines in inducing an immune response that can prevent infection. As Monica clearly pointed out to us, the current first generation vaccines are very effective to prevent the severe outcomes of disease. But to prevent infection, well, they can decrease the risk of infection, but they cannot prevent infection very effective. So I don't see the reason to establish this kind of restriction comparing those who receive it an inactivated vaccine, which we know is less effective compared to other vaccines that, despite being more efficacious, they also have limitation in terms of impede infection. That's the only point I would like to bring to the discussion.
Thank you, Professor Marco. I'll just go to Dr. Monica. I just want to ask a question. I wanted to raise this issue when Dr. Alvin had, is Dr. Monica there?
Yes, I'm here.
Yeah, Dr. Monica, you heard Dr. Alvin talking about, the seriousness of the infection is more in different ethnicity. Did you hear that?
Yes.
Is that a possibility? I'll come to Dr. Nandita also. I'm sure she can also give us an explanation. Is there an explanation?
Can I?
For that? Yeah, just one moment, Dr. Nandita. Let me just ask Dr. Monica regarding a variation in, the severity of the disease and ethnicity.
So that is a very difficult question to answer in our area because we have such a diverse group of ethnicities where we are. What you might see are local effects of clustering of a certain variant that's within a community as they spend time socially through places of worship and schooling in areas that they live. In terms of ethnicity, in terms of outcome, it could be based on underlying medical conditions that might be found in certain ethnicities, such as coronary artery disease, diabetes, hematological conditions. But I don't feel that I have enough information to be able to give you a clear understanding of that, but I could suggest potential plausible reasons as to why that might occur.
Okay.
But as we can see with this virus, this is a worldwide pandemic. If this was really an ethnicity-based driven disease, then you would have seen a cluster in a certain area that would not have passed on or not have been as passed on in the way that it has.
All right.
But I'd also like to stop and say thank you because I do have to leave right now. And I wanted to say thank you for your time.
Thank you, Dr.
And
Monica.
it was a pleasure being here. Thank you.
Thank you, Dr. Monica.
Thank you very much, Monica.
Yeah. So we'll just go to Dr. Nandita and we'll close the session because we have exceeded our time. Dr. Nandita, your explanation on, do you have any explanation on the ethnicity and variation in disease?
So the ethnicity does not determine the infectivity, it determines the manifestation. This is what I've seen. We've actually seen families, 3 in a family die with severe disease. So what is it? It's the genetic pool. And that is what is determining the response to the antivirals, response to convalescent plasma, manifestations of disease, rapidity to manifestation of disease after contracting infection, severity of disease. Yes, definitely genetic manifestation. In fact, there was this talk about myocarditis as well. I'd like to say that just because you've seen myocarditis in one group of people, it doesn't mean it's going to be a universal phenomenon. Again, it is a genetic pool which is going to determine the response to the vaccine. in terms of myocarditis.
Right.
And Dr. Marco, one more thing you mentioned regarding the virus. You said that maybe Delta virus has not, been seen very severe to cause very severe infection in Brazil. What I'd like to say is, no, sorry,
No, not severe infection, but not the same transmission and the same
Correct.
magnitude so
Correct.
far. We have the Delta for more
Absolutely.
than 2 months.
Well taken. So again, it is a genetic pool which is going to determine it. India, we kept thinking, that we are genetically, more sound. We're not going to have a severe second wave, but you see, it happened. So again, it's a genetic pool, and how well your genetic pool is going to handle that variant, that is what determines the quality and severity of infection. It is not presence of an earlier virus or other things. I mean, that's what is my take as a virologist.
All right.
Thank you.
That's a very important point. And I'll give the last word to Dr. Leon. I think he's so quiet because there's not much of contribution from Dr. Leon. But I'll give the last word to you, Dr. Leon. Your final words in this session.
Leon, you told us about Kenya. What about the other East or the other African countries that you are aware of? Is it all say?
It's I mean, maybe it varies slightly, but not too much. I could talk of maybe one of our countries, neighboring countries, which is Tanzania, who, if you all remember, they rejected COVID and said it doesn't exist. So for them, there are no mask mandates. They don't use masks, and a lot of protocols don't exist in the country. And they're our direct neighbors, and there's a lot of cross-border movement from here. So then neighboring, we also have Uganda and Somalia. So some of the issues are similar. Uganda, maybe they try, and they also have the protocol similar to us. But I think the issue of testing for us is still a big issue. Yeah. So even for the children, for example, even if we wanted to test children on a daily basis, it's just not possible. Because we are doing probably less than 5,000 tests nationally per day. Wow. So there's no way we're going to test children. I told you the vaccine numbers for double dose, we are currently at 2 million. No, not 2 million, less than 1 million, about 950,000 in a population of about 48 million.
What about the deaths, Dr. Leon? Number of deaths in Kenya?
The number of deaths is not been too bad. The number of quantified deaths, I'm not sure about the exact numbers as of today, but our mortality rate's probably around CFR, maybe 5%.
5%. Okay.
So could I just pitch in for Dr. Leon there?
Yeah.
Yes,
Dr. Leon, we were in this situation in March and April. We were struggling with immunization. We were struggling with, I'm talking about last year. We had no vaccines. We were struggling with testing. We had people falling sick left, right, and center. So at this juncture, what you should do is anybody with fever, anybody with sore throat, stay home. Doesn't come to school. Doesn't attend work. And second is moving in and out, quarantine. Quarantine really works brilliantly. And the third thing I'd like to say, which I'm sure a lot of people here don't know, singing, shouting, playing games, basically wherever you're running in groups, this is where the maximum transmission happens.
Okay, that's a very, very good point.
Classes in closed doors rather than having them in open, again, transmission happens. Toilets, common toilet for a lot of people, again, that's where transmission happens. So even if you're not masked, these are the ways, even if you're not vaccinated, if you're not masked, these are the ways in which you can reduce the burden of disease.
Okay, can you tell that again? Can you tell us?
Yeah. So basically, transmission of infection happens when you're singing, shouting, screaming, you're playing group activities, you're running in groups, you're talking loudly, because that's when the saliva, from an infected person spreads. Doing this in small groups, inside closed doors without adequate ventilation aggravates it. Using common toilets, this is what we have found, that using common toilets again spreads disease. So having a fumigation session, or maybe, just ensuring that hand hygiene or doorknobs of toilets are cleaned regularly. You have adequate hand hygiene before you go into the toilet, after you come out of the toilet. You have, cleaning of taps and door handles properly done. This will go a long, long way. And anybody who's sick, self-report and stay home.
Right.
So we're doing that even now. In India, we're doing that even now. Self-report, get yourself tested, stay home till your result is out. And yes, Dr. Marco, we have seen Delta variant, Dr. Chan, we have seen with Delta variant multiple negatives. And yet the patient, feels extremely exhausted, tired, and has all the symptoms that come with COVID. Yeah,
right.
Thanks.
So thank you very much. Very interesting discussion today. A lot of learning has happened here. So I'd really like to thank all our speakers. Dr. Monica has left, but she's always happy to join us. Dr. Nandita, again, has become a regular on our program. Professor Marco, thank you for coming in. Your inputs was really valuable. Dr. Leon, I hope things will improve in Kenya. And I'm sure, I think we can only educate.
All the best with that, yes.
Yeah, we can only educate people. And thank you, Dr. Alvin. You got your camera working and we could see you. And thank you for the information from Hong Kong. So to all our regular faculty, participants here, Dr. Lincoln, thank you for coming in. Deborah, Jasna. I think a lot of our course students are also here. Dr. Tara, all of you, thank you very much. And I will hand it over back to Dr. I think Madalena is also here. So thank you, Madalena. Arun, all of you are here. Tara is here, I can see her. Usha. Dr. Russell, I will hand it back to you.
Thank you.
Final words, yeah.
Derek, are you want to add anything from your chat box have been answered, isn't it?
No, I think it was one of the busiest.
Yeah, I didn't go into the chat box.
And it just goes to show the quality of the discussion. I think even if we just put all of that together, of course, I'm incompetent to comment on that, but just the quality of information that is there in the chat box can be published as a research paper. That is my only very humble comment that I can do, because it's, and thank you, Dr. Nandita, for those words of wisdom about simple methods that we can follow and that we must follow. Hats off to Dr. Monica. It was literally, again, having Dr. K.K. Agarwal with us, the depth of detail that she went into, the data that she presented, absolutely wonderful. And that is the way someone should actually present. I'm sure it's an eye-opener for all the students. And thank you again for each one to have answered those questions. So it was a wonderful discussion that went on in the chat box. And really, I think this recording must be shared and everyone must keep a copy of it, because it's really, really wonderful. My compliments to everyone who took part. Really wonderful discussion, and thank you all for sharing the knowledge with all of us. Back to you, Dr. Russell.
Thank you, Derek. Thank you very much, and thank you, Professor Marco, and bringing in some of that information. Particularly, we are focused on understanding the impact on children. We are all now talking about that, and I think that was great. But we probably have the pediatric one, and we will have you again there. Welcome to Madalena. See, the importance here is that we have in the group nearly everyone from all parts of the world are here. You have from the South America, we have the North America, we have Europe, we have UK, we have Madalena Patrico from Portugal. She's there with us, and then we have from different parts of Africa, Asia, and in a way, we are bringing solidarity and cooperation. Today is remarkable that we have each one giving some suggestions, some thoughts, together to, because what we learn is that all of us are in this together, whether we are in whichever part of the globe we are in, we seem to be having to deal with this pandemic. And I think this program that we've kept going has been one of those avenues where we demonstrate solidarity between all of us in this world. So thank you all. Thank you all the speakers, of course. Alvin, who is also Dr. Alvin, thank you very much. Leon has also brought others, and Alvin have had other panels coming here from your regions. So thank you for all your contribution. Professor Marco, thank you for your time, for your valuable contribution to today and so forth. And once again, I think Dr. Barry Schwab would have also told us, but yeah, he couldn't. He was caught up. He's the advisor in South Africa. I'm not sure what exactly is happening, but how different it is from Leon's part of Africa, East Africa and South. But the last time they were also having their own issues there. So anyhow, thank you all, and Leah and Lincoln, thank you for your continued support and care. You're always there and bringing your part of the world to all of us here. Very important, and Deborah, both of them. Thank you all very much, and we shall see you in 2 weeks. Stay safe, stay well, and we'll all meet again. Thank you.
Thank you. Thank you, Dr. Mary. Thank you, Dr. Russell. Thank you.
Thank you,
Thank you very much.
Thank you.
Thank you very much. Excellent presentations.
Thank you.
Stay safe. Bye-bye.
Thank you. Yep. Thank you, Marco.
Thank you.
Thank you.
Good night.
Thank
Bye.
you very much. Thank you.
Thank you. Good night, Dr. Alvin.
Bye. Thank you, Alvin.
Bye-bye. Madlena, good night.
Bye.
Good night,
Good
Madlena.
night. Good night.
No, it's morning for them.
Okay, good night for me. Bye.
It's early morning for me.
All right. Bye-bye.
Bye-bye.
Bye.
Bye. Are you better?
Bye-bye. Much
How
better.
are your eyes?
Much better,
Your eyes.
Madeleine. Much better.
Great.
Much better. Thank you. Thank
Bye.
you. Bye-bye.
Bye.
I will be in touch with you.
Okay. Thank you.
Okay. Thank you. Thank you. Bye-bye.
So fine.